There are lots of different joints in the body, and we could look in detail at a whole lot of them. But instead of looking at all the details of many different joints, I want to focus just on a couple, only to highlight how these different sorts of structures work together and how that affects the functioning of the joint. So the first joint that I want to look at carefully is the humeroscapular joint, also known as the shoulder. The humeroscapular joint is between the head of the humerus and the glenoid cavity of the scapula. That's why we call it the humeroscapular joint. A lot of joints are named based on the bones that are articulating. One of the important features of the humeroscapular joint is the fact that it is very mobile. We have more movement in this joint than we do anywhere else. We have an incredible range up and down, back and forth, as well as rotation. So all of this movement is related to the structure of the joint itself. For one thing, the glenoid cavity is very shallow. We saw that on the scapula. It's a very shallow socket for the head of the humerus. And the fact that it is very shallow is part of what gives it a lot of mobility. Something like our hip, where we have a more curved acetabulum that the head of the femur fits into, is a little more limited in how much it can move. So the advantage of this shallow glenoid cavity is movement. The disadvantage is a lack of stability. Because that cavity is so shallow, it doesn't offer a lot of stability to the joint. So we have to have some other structures involved that help to stabilize the humeroscapular joint. The biceps brachii muscle of the arm connects from the radius up here to the shoulder. It's important for moving your lower arm, but it's also important for stabilizing the shoulder. The tendon of the biceps brachii goes right here over the humerus up to the scapula, and the pressure of the biceps brachii tendon helps to hold the head of the humerus in place against the glenoid cavity. In addition to the biceps brachii tendon, we have several other muscles that help to support the humeroscapular joint. These muscles make up what's called the rotator cuff. The rotator cuff that supports the shoulder is made of the tendons of 4 different muscles that start on the scapula and then connect to the humerus and help to hold that in place. The tendons of these muscles actually fuse to the joint capsule to support the joint. We'll see more detail about these muscles later, but in brief, we have the suprascapularis muscle that comes from the top part of the scapula over to the top part of the humerus. We have the infraspinatus, which comes from the lower part of the scapula over to the humerus. We have the teres minor, which also comes from the lower part of the scapula up to the humerus. And we have the subscapularis from the inside of the scapula that comes around to help protect the front of the joint. Altogether, these rotator cuff tendons protect the posterior, superior, and anterior portions of the joint. Unfortunately, there isn't support on the inferior side of the joint. Because of this limited stability on the bottom end of the joint, when the shoulder is dislocated, which can happen easily enough due to the shallow glenoid cavity, it's usually dislocated downward. So if there's something that fixes the arm in place and then pressure is put downward on the upper arm, it will actually push the head of the humerus right out of the glenoid cavity. Here are some x-ray pictures that can show that very thing happening. The first image is of a correctly positioned humerus. We can see the head of the humerus and the glenoid cavity. In the next image, you can see that the head of the humerus is inferior to the glenoid cavity. This shoulder has been dislocated with the humerus moving downward out of its socket. And this is the trade-off for the excellent mobility we have at the shoulder. If our shoulder wasn't able to complete so much movement, we could have a more stable joint, which would be less likely to dislocate. But because we do have great movement, that has to decrease the stability of the joint somewhat, making it easier to dislocate the head of the humerus. There is some additional support for the humeroscapular joint from ligaments. There are about 5 different ligaments that help connect the humerus to the scapula, but they don't have nearly as much effect as those tendons of the rotator cuff and the biceps brachii do. In fact, some people are missing some of those ligaments and notice no effects overall. Finally, we have 4 different bursae that help to cushion the shoulder and help things move smoothly without rubbing too much on other structures like tendons or parts of the bones. The other joint I want to look at in detail is the tibiofemoral joint, or the knee. The tibiofemoral joint is between the medial and lateral condyles of the femur and the medial and lateral condyles of the tibia. If you remember looking at the tibia, the superior surface of the tibia, where we find those medial and lateral condyles, is very flat. And then we have the condyles of the femur that are going to articulate against that. Because we've got that flat surface, that really would allow a lot of mobility at the knee. But you know the knee only bends, really should bend, in one direction. So we have to have a lot of accessory structures to provide support to the knee and to limit its movement. One thing that's interesting about the tibiofemoral joint is that the joint capsule only encloses 3 sides of the joint. It encloses the posterior and the medial and lateral sides of the joint. The anterior or front part of the joint is enclosed by the patellar ligament. The patella is an interesting bone because it's held in place by a ligament. We have the tendon coming from the quadriceps muscle that becomes the patellar tendon holding the patella in place and then eventually merging down to the tibial tuberosity. And it's that patellar tendon that encloses the front part of the joint capsule of the tibiofemoral joint. If we take a look inside the joint capsule, we see that we have 2 menisci, or articular discs, pads of cartilage, that are found between the tibia and the femur. These menisci are important for absorbing shock, because every time you take a step, or especially if you were to jump or hop, the femur is going to slam down onto the tibia. And without that cartilage to absorb some of the shock, we would be banging those bones against each other too hard, causing damage to the bone and the articular cartilage. Also inside the joint capsule are a pair of ligaments that help to hold these bones in place. We have the anterior cruciate ligament, known as the ACL, and the posterior cruciate ligament, known as the PCL. The ACL is important for preventing hyperextension of the knee. We want the knee to extend until it's straight, but not to go the wrong direction. And it's the ACL that prevents that hyperextension. The PCL is important for helping to hold the femur in place on the top of the tibia and not sliding forward. Without the PCL, the femur can slide forward on the tibia and dislocate. In addition to these ligaments that we find inside the joint capsule, we also have ligaments around the outside of the joint. We have what are called the collateral ligaments. There's a lateral collateral ligament and a medial collateral ligament. And these collateral ligaments help to prevent sideways movement of the joint so that your knee doesn't go from side to side. In addition to all of these important ligaments, we have 13 bursae that help to cushion various areas of the joints and where the ligaments or tendons are going to be going anywhere near the bones. Because we've got all of these ligaments that are holding the knee in place and limiting its movement, anything that forces the knee to move in a direction it's not supposed to go can cause damage to these structures. So we can see a lot of injuries to the knee caused by either forcing lateral movement or by hyperextending the knee. We damage the ligaments that are supposed to be preventing those things from happening. Unfortunately, because we're talking about dense connective tissue, like in the ligaments, or cartilage, like we find in the meniscus, it can be difficult to heal damage to these areas of the body because those are slow healing tissues.